consultants, faculty, and delegates who have come here for the workshop. So it's at the outset, I thank the organizers for giving that we all should do screening for women, eligible women between the age of 30 and 65 years. So what is the purpose of a screening test? It actually modifies the risk of a woman developing cervical pre-cancer and cancer. It doesn't mean that all women who are screened will be positive, but only a certain percent, that to a very small percentage of maybe 3% would be screened positive. Again, screen positive doesn't mean that they have a pre-cancer or cancer. What we need to do is they definitely need further evaluation. So negative women who are screen negative, you will be nicely telling them to go back and come after 3 years or 5 years depending upon the screening test. But those who are screen positive, you should not leave them and you need to evaluate them further. So we all have a standard protocols developed by our own FOXI as well as WHO. Not only these two organizations, any colposcopy organization worldwide have got their own protocols. But for my lecture, I have basically used our FOXI recommendations and WHO recommendations because these are easier in our country to follow. So we have again several approaches of screen and treat, screen, triage and treat, see and treat. So wherever it's needed, I'm just going to say, but the subsequent lectures in the rest of the day are going to cover all these protocols. So after understanding the need for screening, we all know that we will do a primary screening test. So if the primary screening test comes positive, sometimes we need to do again another secondary screening test to triage further whether the lady needs immediate treatment or whether we need to refer them to a colposcopy and biopsy. As it's very clear, if the secondary screening test is negative, then probably we can call them back for a repeat screening after a certain time. So the understanding is after a primary screening test, most of the times we do again another secondary screening test to triage for further management. So we all know that the standard screening test what we are using. So this is just suppose you are doing VIA as a screening test, and the first picture is a woman whose cervix is seen without application of acetic acid, and the second one is after application of acetic acid. You are seeing aceto-white changes on her cervix. So if you see a VIA positive, what are you going to do? So coming back to our FOXI recommendations, between 30 and 65 years of age, if somebody is tested positive by VIA, what are we going to do? So again there are several approaches. So most of us are very comfortable, especially in the community screenings, are to avoid the dropout. We follow the screen and treat approach. So when you are following the screen and treat approach, if the lesion is suitable for ablation, you can do cryotherapy or thermal coagulation. If the lesion is not suitable for ablation, or you don't want to over-treat anybody.
Tissue basis basically is when you are applying acetic acid on the epithelium. So different epithelium will react in a different way. One, she is covered. The columnar epithelium is appearing red because it is a single layer epithelium and it doesn't have any glycogen, so it will not stain mahogany brown with the iodine. So while the squamous epithelium will turn aceto-white if there is a dysplastic epithelium along with it. If it's a normal epithelium, all the layers are normal, what Dr. Suchi has said, layer 1 to 5 are normal, the light is going to go through and through, penetrate to the epithelium, and underlying stroma, there are blood vessels, so it will reflect back to the operator as a pink color. So that is the genesis of aceto-whiteness. If during that, in the whole epithelium, if there is something abnormal, there is dysplasia. If there is dysplasia, there will be a lot of nuclear material in the cells, so it will block the light. So that area you will see as white patch. Whether you do VIA with the naked eye or you look at the colposcopy. And when in the same abnormal epithelium, when you are applying Lugol's iodine, so an abnormal cell will not have glycogen, an inflammatory cell will not have glycogen, frank malignancy will not have glycogen, so it is not going to take up that iodine, so it will not be turning mahogany brown. So that is how. And then you have different grades of it. So that's the scoring system. I think that Dr.
once the patient reaches to us, we should not lose this opportunity to do the first speculum examination. That is must. Once you have done the first speculum examination, you can see by your naked eye, and at the same time you can take the LBC or pap smear, whatever the facility is available, and at periphery via also. By this, ultimately it is going to help our patient to screen out and to treat in the early stage. And by this, definitely we can reduce the morbidity and mortality related to the cervical cancer. And this is the only cancer which we can detect in an early stage. So that is very important, especially our youngsters. They always depends on the ultrasound. Ultrasound will tell there is a growth, but nobody wants to see the condition of the cervix, which we can do by only first speculum examination. Thank you, Ruchika. Thank you so much.
Just one question. In a hysterectomy patient with a report of CIS or CIN3, what will be the screening protocol after hysterectomy?
We will go for a single, this thing. One HPV testing or along with co-testing cytology, and according to the further report, we will go for the FOXY guidelines.
Yeah,
How long?
actually, once
How long we need to screen?
20 years.
20 years.
Yes, that is what I was
So very well presented, Ruchika. There was only one point regarding the LBC and pap smear. It is now a worldwide accepted thing that LBC is better than pap smear. Of course, the sensitivity and specificity may not increase, but for the pathologist, the inter-observer variation that comes with the pap smear has been taken over by the LBC definitely with the automated. Of course, cost is there, but wherever possible, it is being replaced by that. And so, that is another extra advantage, but as far as for the pathologist, definitely LBC will be a better approach than going for as a cytologist.
Now the WHO, after the WHO guideline, the recommendation is to do HPV only. The co-test does not, co-test is not recommended. It's only HPV. And if HPV is positive, then the triage is by cytology or PI or corpus.
One more point. I think this LBC has advantage over the conventional PAP that it decreases the unsatisfactory reports of the. So it's useful for the the gynecologist as well as for the pathologist. And second point, it is cost effective also. When you compare it with the conventional, overall in masses it is cost effective than the conventional one. Only thing is you need to, and thirdly, you may not need a very expert cytologist as we need in conventional one.